As you hold, it's another THCB update here with another physician entrepreneur. This is Dr. Lucienne Ide, or Lucie. She is the CEO of Rimidi, and we're going to find out a bit more what Rimidi does. Been doing this for a little while, living in the world of helping support clinicians support patients with remote monitoring and other tools. So, Lucie, I got that all wrong. Tell me what Rimidi does.
Thanks, Matthew. So we are, as you were saying, in the business of helping support better care for chronic disease management. And under that umbrella lives a lot of different activities and, impacts that we try to have both for the healthcare providers and systems who we work with and the patients who they serve.
Fair enough. So let's sort of start at the flavor. So there are two ways to think about this. What is the product / service that you deliver to whom? Where do you start and where do you stop? And then we'll talk a bit about which conditions and who you deliver to. Let's start with if I hired Rimidi, what would you do for me?
Yeah, so if you hired Rimidi, we would be partnering to help you improve care, usually in a specific area or set of clinical conditions. And what I mean by that is, as you said, there's technology, there can be services involved, but it's like enabling that holistic, proactive management of a patient population. And doing so by aggregating better data from their EHR, from devices those patients might have at home. That's the RPM part, is they might have a connected device at home. They might also be reporting symptoms and social determinants and experiences of their care through patient-reported outcomes measures. Rimidi's bringing all of that together into an efficient workflow to help drive the insights to the care team of which patients need their attention and what kind of help they need.
Okay. And the tools that you deliver, tell me how they integrate with or how they work and compared to what's typically out there now. So most clinicians now have an EHR, obviously depending, inpatient, outpatient, big system, small system, it might be a different system. Some of them have some level of population health management on the top, which either gets used, doesn't get used. There's different interests based on how people get paid and how their clinical philosophy about how to manage population when they're not in the physician's office. So what types of tools are you providing? And then who are they aimed at? Who's actually using them within the organizations?
Sure. So we are providing tools, around specific chronic conditions across the board on sort of the cardiometabolic and chronic disease space. So diabetes management, hypertension, heart failure, obesity, fatty liver, COPD, asthma, chronic kidney disease, pretty broad swath of conditions. And yes, everybody has an EHR, right? Their EHR, as you said, might have this population health overlay. The disconnect there is, so a pop health platform tells me how I'm performing on key measures across my population. It might identify what patients have a gap in care. It doesn't take me through to that next step of like, okay, so what? How do I fix that? How do I make an impact on that patient? And, if I'm a healthcare system, I can guarantee you they have limited IT resources, they have limited nursing resources, they have limited clinician resources. And the way we've done this historically of managing a chronic condition was like man-on-man defense, right? And by that, I kind of mean you threw nurses at it if you wanted to actively manage better outcomes in something like diabetes. That's not scalable, it's not cost effective. And by the way, those nurses don't exist anymore. So technology's role in my mind is really, how do we make that efficient and scalable and cost effective to be able to have this population down to individual patient sort of capability of managing the whole population, but making an impact to each patient. Because I'll often say, like, you can't change the outcome of a population without changing the outcomes of every patient who's in that population. So that's what we're doing. Who uses it? These are, care teams made up of usually diverse sets of providers. So your day-to-day, right? It's probably nurses, some medical assistants, case managers. We work with pharmacists and pharmacy techs. It really depends who that organization, has on staff and is involved in their care management. And then they're escalating patient needs to a provider, to a nurse practitioner or a physician or a PA if they need to make changes to, therapeutics.
I see. And how does the tool that they're using integrate with the other stuff they're using? Prominently the EHR, you're taking data out of it, but or are they really sitting in Rimidi all day to manage that process?
Right, great question. So, I came from clinical medicine. I lived through the go live of, paper to electronic health records. And I really appreciate, right, the pressures on clinicians of like everything has to be in that EHR because that is their experience from, 7 a.m. to 6 p.m. every day is, all of their activity lives there. We as Rimidi made, a bet on interoperability a long time ago in sort of the mid 20 teens that as Fire was coming online, that made a lot of sense to me and to our team. So we were very early architecting our platform to be sort of EHR integration and Fire first. Because my goal is that that end user doesn't actually know that we exist. They think that their EHR has this great new module or upgrade because it's so seamlessly integrated into their workflow.
All right. So let's talk a bit about the organizations. I think when we first met, you were mostly targeting diabetes, and now there's a whole range of them. There are different types of entities, big, small, specialized, primary care, etc., who are managing or not managing these patients. A lot of these patients are not well managed, as we know. And then there's different flavors of patient, right? Depending on age, health plan, Medicaid versus Medicare, Medicare Advantage, etc., all the rest of it. Is there a sweet spot for you, and in terms of types of organizations that you're supporting? And if so, where did you start and where are you growing to?
So let me sort of where we started, because it was before there were specific reimbursement pathways around remote patient monitoring. And we really started working with risk-bearing entities, the early initial accountable care organizations, capitated groups that take full risk on their patients, because those were the organizations that had alignment around delivering better patient outcomes, which I would venture to say everybody wants to deliver better patient outcomes. The question is how to do that in a financially sustainable way. So those groups had that alignment, right, of their finances with quality outcomes. So we still work with a lot of those groups, Medicare Advantage groups, accountable care organizations, risk-bearing entities. That's great. Then along come reimbursement codes in 2019 for this thing called remote physiologic monitoring that we all now just call RPM. And that really opened up the market to fee-for-service practices who wanted to do this, but they didn't have, a magic pot of money to become an ACO overnight and be able to hire a care management team. And so it was really a nice way to help them bridge. And I think RPM and value-based care are actually quite aligned. And, in my mind, it's these reimbursement pathways are something CMS, initially Centers for Medicare and Medicaid, put in place as like training wheels, right? We're going to pay you to practice medicine in this more proactive way, because someday we're going to fully capitate your payment model and you're going to have to be good at this. So in the meantime, take this fee-for-service payment and build the infrastructure and the know-how of how to proactively manage a chronic health condition in your population. So, within those worlds of, value-based care orgs, those tend to be bigger organizations, right, who are doing risk-based contracting. In the fee-for-service world, we'll work with independent groups, multi-specialty practices, all the way up to big academic medical centers, sort of equally well. It's, really the technology doesn't need to be different to meet the needs of those different groups.
And the flavor of the patients is it still mostly with diabetes and other cardio, or if you went down the list of a number of different conditions, is it equally spread across them? Who are we talking about?
Yeah, we do spread across them. We still do a lot of work in diabetes. We integrate to the 2 leading continuous glucose monitors on the market. So that drives a lot of interest in our platform because we're one of the very few companies who have access to both Abbott Freestyle Libre and Dexcom data for CGM. But we do, equally a good amount of work in hypertension management, heart failure management, obesity, maternal, high-risk pregnancy with gestational hypertension or gestational diabetes. So it's a good mix. And one of the reasons we have expanded our portfolio is many of these patients have multiple conditions,
Of course.
right? And the health systems, it's, as I mentioned, there's this IT resource constraint problem. And so it's very hard for them to implement an IT solution for every individual condition. They want to get as much bang for their buck as they can out of any vendor. So we were kind of getting that pressure on both sides of, hey, that thing you do for us in diabetes, some of those patients also have poorly controlled hypertension. Could you do the same thing for us there? And then the IT groups are saying, we got you integrated to our EHR, you went through our cybersecurity and technology review processes, and the 1,000 hoops you jump through to contract with one of these very large health systems. If you could do more things for us, that would be great, because then we don't have to bring on another vendor.
Right. All right. Well, let me ask you a little bit about the company. You've been going a while now, and I think if I recall rightly, your sister is the COO. Is that right? Did you force her into doing that? Was that correct? Was I correct in saying that? I think I was at one point. I don't know. Some semi-family business, but give me a sense about how much you raised, and then give me a sense of where you are with the number of clients. You just hinted at some same store growth there, but give me a sense of that where you are with the number of clients and where the scale of the organization.
So we have clients, across the country, as I said, ranging from, very large health systems to community practices, federally qualified health centers, rural health clinics, over 60 clients across those different
Ballpark,
categories.
how many patients are under management?
Tens of thousands of patients,
Okay.
Sort of in active management. And then, some of those systems, we do broader population health insights for them. So that gets into the hundreds of thousands of patients who might be in that total pool that we're helping them identify. Over 30 people. We're based in Atlanta. A lot of them are here.
And you raised how much? I think I saw notes around 13 million a while ago. Is that correct? Or have you raised more or less? Or was it false reporting?
It's probably around 15. Yeah.
Okay. So not nothing then. All right. So at some point, some investors will be interested about getting their money back. We'll see. So let's talk about two things. One is the overall market. You mentioned the back to the old question of value based, and I was on a conversation on LinkedIn the other day, noting that a lot of people saying value means cheap outside of healthcare. So maybe that's not the best term, but versus RPM, which most people think stands for remote patient monitoring. And then CCM and all these other versions of the RTM and all the stuff that's coming out of Medicare. What do you think, for the, I recall that I wrote a big rant up the other day, and I recall I heard a lecture from somebody talking about how they'd done, the medical groups they were working with were, had 90% of their patients with hypertension were at target, whereas I think the California average is 40% and Kaiser's at 65 or 70%. My impression is that there is still a massive problem in getting those patients who have, are above risk or have the early stage of these conditions, but actually in the hospital, getting them managed at all is still a very big problem. How much do you think the addition of RPM, the steady but slow encroachment of ACOs and value-based care, how much are we getting close to fixing this overall problem? Or as a clinician, or are we still just scratching the surface?
30,000-foot view, I think we still have a lot of work to do in this space, right? And part of that is just the US healthcare market, that we have been lousy historically at proactively managing the health of individuals, right? We are the best country in the world. If you have a serious medical problem, you need a procedure done, people come here from all over the world for that. But if you need really great primary care, I would argue we're not the leader on that.
Yeah.
So plenty of runway to keep improving. I do think we're seeing, we see it in our clients, and I know others, share their results and do as well. We see the benefit of, these interventions, and I'll call it an intervention, not a technology, because it's not the technology, right? It's the intervention with the patient, which is the people powered by the technology, additional education. It's all of that, right? And the impact that that's having on a patient. And I think, one good example of that is a lot of our clients run both RPM and CCM programs concurrently, because some patients need the care management type engagement of a chronic care management program, right? They need that care plan and sort of to stepwise walk them through how to improve their outcomes. It's less about having daily blood pressure readings and really being focused on that one metric. Other patients, right, are really appropriate for and benefit from that daily engagement. If I'm taking my blood pressure, I get feedback on that, right? Both positive and negative. And that motivates me to be compliant with my meds, to be compliant with taking it. And it allows my care team the data to know when they need to make an adjustment. So I just, sometimes I feel like we get a little fixated on some of these individual codes or individual transactions, and we lose sight of the fact that it's, multiple tools in the toolkit to address this overarching problem of how do we do a better job of managing these chronic conditions, to your point, and that, that's the end game, is to prevent people from having complications. People don't die of having hypertension or diabetes. They die of the complications when those are poorly managed.
Right. So slightly different philosophical question, or maybe not philosophical question, maybe a practical question. You seem to have you've made a bet with your company on the fact that it's you're supporting health systems, providers, clinics as they engage in this process. Obviously, there are other people getting paid in this country to look after people. Some of them delegating that risk to these clinics, and others doing it themselves. I'm talking about health plans, some governments, in some cases employers, and obviously the Medicaid program. Who do you think should be in, and some people believe that consumers should do it all themselves, but who do you think should be, and who do you think will be in charge of like this overall idea of getting that group of patients to be, as you said, monitored, managed, and not having the complications that cause them to die or have very expensive hospital conditions? Who do you think we should be, holding to account here?
I mean, this is the big disconnect, right, of our healthcare system of payer, provider, patient. And, they each play their own role. And sometimes the person
even have pharma companies now like building programs, drugs and stuff. Yeah. So they're even more, right?
Yeah. So, I mean, where do we see alignment of those things, right? We see alignment of that in providers who carry full financial risk, right? And now their benefit, and you need both parts. I think one of the hard things is for a health plan is, number one, if they're intervening with a patient population, they don't necessarily want to take over the clinical management of that patient population, right? They can engage them, they can help make sure they refill their meds, but they're not necessarily going to change their prescription because they're not the healthcare provider. And that patient may churn off of their plan next year. And so, I've gotten that response from health plans of like, well, I carry the cost of intervening and somebody else benefits next year when they move to their plan, right? So, that's sort of why we have stayed true to working through the providers. It's where CMS wants to go. They've said by 2030, they want every Medicare beneficiary and a, risk-based contract. So they are pushing that onto these providers. And I overall think that's a good thing, right? We've got to get the alignment so that the people who can control the outcome are the ones who benefit from the good outcome. And, in my mind, a certain segment of the market that's going to be the providers who are serving that role of taking care of the patient, and then they should be rewarded for doing a good job of taking care of those patients.
All right. Well, I think you staked your claim in the right place. So fingers crossed that we might start getting there, and that CMS actually.
It's going to take 10 years longer than I thought, but that's okay.
It's American healthcare. It's 15 years in the future and always will be. This great stuff. All right. Last question, Lucie. What is next in the next couple of years for Rimidi? What do you think you're going to do to help push that ball up the hill or down the hill or wherever it is?
Yeah, I mean, I think we will continue to see these pressures on workforce. I had a large healthcare system tell me that their physician shortage of the retirements they see coming, if they hired every medical school graduate in their whole catchment area, they would still be short thousands of physicians over the next 15 years. So like, that's not going away. And there's all this, hype and buzz, and I'm sure many interviews you do around the role of AI and technology in healthcare.
If I didn't ask you how AI was going to fix this.
Thank you. Yeah.
But I can, but you can just ask it yourself.
I'll put it out there, right? Like, there is clearly a role for how we continue to help everybody practice at the top of license, is the way I like to think about it. So we will have scarcity of resources, because of demographic shifts and everything else, of physicians and nurses and everybody else in that chain. So how do we help them have the most impact on patient care? Technology like ours, and this will be part of our shift of continuing to process the data, elevate the highest need patients, have the humans doing the part only the humans can do, and let the technology do the part that the technology can do. I I think that's a big part of it. And then, we'll see innovations in medical devices. And we're constantly looking at those that will make it more passive for patients, for some of this data to be collected and shared. I think the combination of those things, right, of growing data streams that can be more passively collected and then enhanced analytics around that to really leverage our medical professionals to the highest degree is, what we need to focus on the next 5 years.
All right, fantastic. I've been talking with Dr. Lucienne Ide. She is the CEO of Rimidi. Lucy, thanks for your time.
Thank you.